Decoding DX is proud to be supported by AMBOSS, a medical education platform with an expansive resource library and USMLE-style question bank.
Hi, welcome to 10 Clinical Minutes. I'm Brianna, and in this episode, we're going to be talking about respiratory failure interventions. Let's start off with some definitions. There are two main types of respiratory failure, hypercapnic and hypoxemic. Hypercapnic respiratory failure is when your arterial CO2 is greater than 50 millimeters of mercury. This happens when there's impaired ventilation, which means impaired airflow to the alveoli. This can happen because of a pulmonary cause, neuromuscular, or a central cause, meaning that you don't have the drive to breathe. Etiologies of hypercapnic respiratory failure include those with a normal AA gradient, meaning that there's hypoventilation, but the gas exchange itself is normal, or elevated AA gradients, which indicate that there's something going on with the pulmonary gas exchange physiology. For more on an AA gradient and what that means, go ahead and watch our video on hypoxemic hypoxia. Hypoxemic respiratory failure happens when the partial pressure of oxygen in the blood, PaO2, is less than 60. This happens because there's impaired alveolar gas exchange. There are many different etiologies to this, including pneumonia, ARDS, or diffuse alveolar hemorrhage. Isolated hypoxemic respiratory failure happens with shunting, VQ mismatching, fibrosis, or PEs. But more often than not, we have combined respiratory failure with hypercapnic as well as hypoxemic. This can happen because of a bunch of etiologies. The most common would probably be COPD and diffuse lung disease. A side note, a standard ABG readout will have 4 numbers separated by dashes. In order, this is the pH, the PCO2, the PO2, and the bicarb. It's important to note that bicarb is calculated. It is not measured. So when you're doing different math equations to figure out your acid-base status, you need to use the measured bicarb from a metabolic panel, not the calculated bicarb on the ABG. Normal physiology of gas exchange happens when we have good ventilation bringing air in that then can be exchanged through the capillary membrane to bring CO2 out and oxygen in. Hypercapnic respiratory failure happens when there's not enough of that air coming in. This means that the air in the alveolus just kind of sits there without actually being breathed out. Hypoxemic respiratory failure happens when there's impaired gas exchange. This means that we're getting enough air in, but there's something blocking the ability of that gas to communicate with the blood in the capillary. I highlight these key physiological differences because this explains the different ways that we need to treat different types of respiratory failure. With hypercapnic respiratory failure, the problem is ventilation. So if we are able to improve ventilation by pushing more air in and out of the lungs, then we're able to overcome that type of air just kind of sitting in the alveoli and instead replace that with good air movement in and out. Hypoxemic respiratory failure, on the other hand, doesn't necessarily have a problem with ventilation, but we just need to get extra oxygen to that alveolar membrane so that we can get it into the blood. So if we treat it with extra oxygenation, we're able to increase the amount of oxygen hitting the surface area of the alveolus, thereby getting more into the blood. Some extra terminology to go over that you'll see on the wards and in the ICU. FiO2 is the fraction of inspired oxygen in the air that you're giving the patient. At room air, this is 21%. But if we're giving the patient supplemental oxygen, this will be greater than 21%, and we can control that based on the devices that we're using. The wall oxygen device will give 100% oxygen, but the key is that the type of delivery method that you're using will allow entrained air to contaminate that 100% O2. This means that the patient will get somewhere between 21 and 100%. And again, that depends on the device, and we'll go through some of those devices in a bit. The reason that this happens is because the amount of oxygen coming from these devices has kind of a low flow rate or a poor seal, meaning that some of the oxygen can leak out and the other air can seep in. The flow rate is the volume of oxygen delivered in liters per minute. This is how we quantify how much oxygen we're giving our patients. You're probably used to wall flow meters that are on pretty much every wall in the hospital that have a little ball that show you how much oxygen is being delivered to the patient based on what you're setting it to. With this flow meter, you're going to read the flow of oxygen based on the middle of the ball and where that hits based on the marks on the meter. But if you have a device like a heated high flow nasal cannula, with that ball, you're going to read at the top. In this example, the top of that ball is hitting at 55, so your flow is going to be 55 liters per minute. So let's start going through some different types of delivery devices. The bag valve mask is what you probably are used to from BLS or ACLS different simulations where you would use them in a code. It's appropriate to use a bag valve mask in a short duration of respiratory failure or when you're acutely trying to transition a patient or stabilize them in an acute situation. It is not a good idea to use this for a long time if the patient is hemodynamically unstable, they have lower levels of consciousness, or they can't clear their secretions. Nasal cannula is probably the most common and most familiar of oxygen delivery devices, and this can give a flow of 1 to 6 liters per minute of oxygen. This equates to 24 to 40% FiO2, and an easy approximation for this is that you get about 4% of additional oxygen per liter per minute that you increase the flow of the oxygen. So 1 liter gives 24%, 2 liters would give something like 28% oxygen. This is good for stable patients that are alert and they have a pretty stable respiratory pattern. But these can easily fall out or the patient can inadvertently pull them out. It's not terribly uncommon to walk in on a patient and have their nasal cannula on their forehead or something. And we're not super precise in our ability to give exact amounts of PaO2. A face mask, on the other hand, can give a little bit more oxygen, 6 to 10 liters per minute. And this might be a better option for patients that can't tolerate the nasal cannula or if they're mouth breathers. You'll have a lot of patients sometimes that will be mouth breathing while they're asleep, and then the nasal cannula may not be able to get good oxygen to them because they're pulling in most of their air through their mouth. So a face mask is good for stable patients that may be mouth breathing and just have mild oxygen requirements. A non-rebreather is able to deliver even more oxygen at about 10 to 15 liters per minute, which gives an FiO2 of about 60 to 80%. There's a little valve on these devices that prevent rebreathing of the exhaled air, so that increases the amount of oxygen the patient gets because they're not rebreathing their own CO2. Non-rebreathers are good for patients that need a high amount of oxygen pretty quickly, such as in a rapid response when a patient might be decompensating. But a non-rebreather is not a long-term solution, and it can provide a false sense of security in a patient that's acutely decompensating and needs to get to an ICU level setting. So non-rebreathers are good for rapid intervention, a patient who's ventilating well so they don't need extra pressure support, and they're on their way to getting more definitive intervention. A Venturi mask is a little bit more uncommonly used in the hospital. It can give anywhere from 2 to 15 liters per minute, meaning 24 to 60% FiO2. There's a particular valve that you can use in exchange for different sizes that will give a very predictable amount of room air that is drawn into the oxygen jet so that we can get an extremely precise amount of oxygen delivered to the patient. This is good for patients that need a very precise measurement of oxygen when you have a clear PaO2 goal like in chronic COPD. Hypoflow nasal cannula is pretty much what it sounds like. It's a nasal cannula that can deliver flow more than a normal nasal cannula, so 6 to 15 liters per minute, meaning an FiO2 of about 60 to 100%. The idea behind this is that a higher flow of oxygen can help wash out extra CO2 from the dead space in the airways, and hypoflow nasal cannula can be humidified, so it can be better tolerated by patients as the air isn't so dry. So it's good for the same type of clinical situations as a nasal cannula, but if they just need higher oxygen requirements. So we're talking about stable patients that can protect their own airway, they're appropriate for floor status, and they just need more than 6 liters per minute of oxygen. But it's important to know that this can be uncomfortable for some patients because of the high flow. And again, if they're mouth breathing, it's not going to be as effective. On the other hand, heated high-flow nasal cannula, which became very popular during the COVID era, can deliver up to 60 liters per minute of oxygen. And it's able to humidify and warm the air, so it's much more tolerable and comfortable for patients. This extreme amount of flow of oxygen, up to 60 liters per minute, can effectively provide a small amount of PEEP to the patient, which stands for positive end expiratory pressure. For every 10 liters per minute of flow, you get about a 0.7 millimeters of water PEEP. So if you're familiar with ventilator settings, this can help prop open some of the alveoli that might be collapsed. It's appropriate to give heated high-flow nasal cannula to patients that have a very high oxygen requirement and might have end-of-life preferences that include not being intubated. But importantly, they still need to be able to protect their own airway. In most clinical situations, a patient has to be moved to the ICU in order to be put on heated high-flow nasal cannula. And the reason for this is that they are very high risk for needing intubation. So if a patient has tenuous enough respiratory status to need heated high flow, they need to be in the ICU where they can be very closely monitored in the case that they do need intubation or other types of intervention. Next, we're moving on to what we call non-invasive positive pressure ventilation. There's 2 types of non-invasive, CPAP or BiPAP. CPAP is able to stent open airways to relieve upper airway obstruction. CPAP has a constant continuous pressure. Starting pressure is typically about 5 centimeters of water, And you can increase that pressure by a few intervals to a max of about 20. Which pressure setting the patient needs is typically determined based on a sleep study. Patients who benefit from CPAP most commonly is obstructive sleep apnea, and sometimes can be used to help relieve obstruction in COPD and pulmonary edema. But again, in these settings, you're not actually fixing the underlying cause with the COPD or the pulmonary edema. You're just helping to relieve an upper airway obstruction component to their difficulty breathing. Key contraindications to CPAP include hemodynamic instability and anything that might threaten their ability to protect their airway. This is critically important if their patient has trouble clearing secretions or if they may have nausea or vomiting. Because if the patient isn't able to pull their own mask off in the event that they need to protect their airways, that means that we cannot put the mask on in the first place. Another thing is that if the mask doesn't fit well, it's not going to work. There are a variety of different masks that we can try, and respiratory therapists are fantastic at finding a good fit for the patient. It's really important for the patient to understand that they need to have the mask on in a way that fits them well in order for it to do its job. BiPAP, on the other hand, has two different pressures, an inspiratory and an expiratory pressure. The BiPAP works by improving ventilation and decreasing the work of breathing. BiPAP is used when someone has hypercapnic respiratory failure. Remember, the pathophysiology of hypercapnia is that we just don't have good ventilation, so the air just kind of sits in the alveoli and doesn't get exchanged properly. So in order to address that, we provide an inspiratory and an expiratory extra boost of pressure to the patient to help them move air in and out. Acutely, this is seen in all sorts of illnesses like ARDS, sepsis, and COVID. More chronically, we can see it in patients with COPD and obesity hypoventilation syndrome. These chronic patients oftentimes will need BiPAP just baseline at night to help them sleep, but acutely, this is called rescue BiPAP and usually requires ICU level care. Contraindications to BiPAP are pretty much the same as with CPAP. If there's anything that might compromise the patient's ability to protect their airway, or any concern that they would not be able to clear their secretions or that they would vomit, you cannot put that mask on them because that's an extremely high risk of aspiration. You'll see two big numbers with BiPAP settings, the inspiratory pressure or IPAP and the expiratory pressure or EPAP. The IPAP is what helps to open the lower airways or the alveoli. The EPAP is what helps keep the upper airways open, kind of like CPAP. So you can think of the BiPAP as CPAP plus extra inspiratory pressure. The delta P is the IPAP minus the EPAP, and this is your effective ventilation pressure. If you have a patient, for example, in the ICU that has persistent hypercapnia, you need to increase their delta P. If you were to increase the IPAP and the EPAP by the same amount, you're not really going to help them get rid of their extra CO2. You need to do some combination in order to increase the delta P to increase their effective ventilation. You might hear the term trilogy thrown around by pulmonologists or intensivists. This is just a type of BiPAP. It's a pretty special, expensive machine where the pressures will auto-adjust to the patient. The main thing that I want you to know is just that it's a type of BiPAP, especially for patients at risk of hyperventilation, but you'll hear it thrown around, so I just wanted to include it in here so you know what it is. Lastly, intubation obviously is the most intrusive, invasive type of artificial ventilation. There are many indications for intubation. That's beyond the scope of this talk, but I also highlighted here some typical initial settings. Different initial settings of the ventilator depend on the preference of the doctor as well as the clinical setting. Here's a summary table. I'm not going to run through this one by one, but feel free to pause, go through this on your own, and take screenshots for your own learning. Here are some references. Thank you so much for joining us on this episode of 10 Clinical Minutes. Please send us an email at info@decodingdx.com with any feedback. And also please like and subscribe. We'd love to have you hang out with us on our channel. Thank you so much. Talk to you next time.